Hey everybody, welcome back to Clinical Physio with me, Khalid Maidan. In today's video, we're going to be taking you through active range of movement testing of the cervical spine. We're going to show you how to complete each test and the key muscles influencing each movement. If you'd like more information about active range of movement testing, check out our other video titled Why Test Active Range of Movement, as this gives you all the clinical reasoning you need behind these tests. Now, whenever we're looking at active range of movement testing, we need to think about three key things: P, Q and R, pain, quality and range. If you're not familiar with P, Q and R, here's a quick recap. If you do know what we mean, go on through to our main video. So as we have said, when testing active range of movement of any joint, we need to consider P, Q and R. P for pain, Q for quality of movement and R for range of movement. In terms of pain, if pain is present, we know that there is a dysfunction within this movement, which may be causing our patient's problem, and will likely direct further testing to this area to try and isolate the source of the pain. If pain is not elicited as part of the examination, the therapist can move on to the next stage. For example, if there is no pain on active lumbar spine movements during a hip examination, the lumbar spine can be ruled out of the initial investigation. In terms of quality, good quality indicates that the brain and local tissue are both happy and able to perform the movement. So what does that look like? It means that the patient will look very willing to move and have sufficient power in movement with good control and coordination. If these are lacking during the movement, quality can be questioned, and thus likely direct further testing to establish why the movement is of poor quality. For example, weakness, which could be due to a myotomal weakness from a spinal pathology or a deconditioned muscle from the local area. In terms of range of movement, too much or too little range can indicate a dysfunction within the movement and could also help us identify the patient's condition. As a therapist, it is always important to use the range values within your movement test as objective markers and for you to compare the specific range values in each treatment session. It is important to know the range at which your patient's pain starts and the range at which the movement ends, as often these two values will be very different. For example, if we only measured the movement at which pain starts, we do not actually know how much range the patient can achieve. Essentially, a lack of range indicates that there is a stiffness or a weakness which is preventing full movement. So classically, we test active range of movement of the cervical spine with the patient in a sitting position. And whatever posture your patient adopts when they sit on your plinth is the posture in which you should complete your tests. So for example, if the patient sits like so on the plinth, then make sure you test it in this position, because this is the posture that they use whenever they move their neck during their general day. Do not correct it, because then you're getting an abnormal sign of what your patient normally does. So now that we've done that, we're going to look at the shoulder. And we clear the shoulder by asking our patient to actively flex their right shoulder and then to actively flex the left shoulder, like so. And when we do this, we need to see if this reproduces the patient's pain around their neck area. If it does, or if there's a clear mechanism of injury that links the neck and the shoulder, for example, if your patient generated their neck pain whilst throwing a ball, then you should complete the rest of your shoulder assessment. However, if this test is clear and doesn't reproduce the patient's pain, you can move on. And we're going to move on by starting our cervical spine range of movement testing with flexion. In normal practice, the therapist should stand lateral to the patient so you can clearly see the movement at the cervical spine. I'm going to stand behind the patient just so you can see more clearly. We're going to ask our patient to bring their chin down towards their chest like so. And then, if this movement is not painful, we can apply some overpressure by pushing forward on the head like so to further stress the joint structures. In general, it's important to use the words chin to chest rather than simply look at the floor, as this doesn't reproduce classic cervical flexion. The muscles involved in this particular movement are now shown on the screen for you to look at. So now that we've done that, we're going to consider P, Q and R. P for pain, Q for quality of movement and R for range of movement. So in terms of P, classically it is the discogenic structures around the neck that are most irritated with cervical flexion. However, we know from physical examination alone that you can't rule out other structures in the movement. However, whether the patient gets their pain around the local area in terms of the neck or in peripheral regions, you know that cervical flexion has aggravated structures which are causing the patient's pain. So it might well be that changing cervical flexion is going to be a part of your treatment. Next, we need to consider the quality of movement. And to start with, when the patient flexes, you should see whether the flexion is coming from the upper cervical spine or the lower cervical spine. So, for example, in terms of the upper cervical spine flexion, the patient may do this, where the lower half of the cervical spine is very stiff. It may also be the case that, in fact, they're achieving too much lower cervical flexion, like so, where you can see that there's a lot more flexion in this region. Either way, consider if that kind of position aggravates the patient's symptoms, because if it does, it might be the lack of lower cervical spine flexion or the excess of lower cervical spine flexion, for example, that might be triggering their symptoms and might be something you need to test further. Next, we're going to see if there's any particular side flexion whilst the patient flexes their neck. So, it might be that when the patient flexes, they bring their head down to the right as well as flexed, or down to the left as well as flexed. This might be for a couple of reasons. It might be that they've done this intentionally as this relieves their pain rather than if they flexed with their head going down the middle. It might also be that there is a weakness or a stiffness somewhere around the cervical spine that is forcing them to produce this movement. So again, this is something you might want to look at as well. So that's in terms of Q for quality. And finally, R is for range. The normal expected range of movement cervical flexion is 50 degrees. So if the patient is not achieving this, that shows that there is either a stiffness or a weakness that is preventing movement. In general, within the cervical spine, flexion is an open packed movement. So that means that there is not so much stress on joint structures during the movement. However, it may be that soft tissue is being irritated whilst this movement is occurring, and so this is something you consider as part of your assessment. So next we're going to test cervical extension. Classically, the therapist should be standing laterally to the patient. However, just so that you can see things more clearly, I'm going to be standing behind. And for this movement, we're going to ask our patient to look up towards their ceiling so that they can achieve cervical extension. If this is not painful, we may apply some gentle overpressure. However, it's important to note that cervical extension is quite a provocative movement, so be careful with the amount of pressure that you apply. The muscles involved in cervical extension are now on the screen for you to see. So now we're going to analyse P for pain, Q for quality, and R for range of movement in relation to cervical extension. And first, P. Extension is the closed pack position for the cervical spine, and therefore it's most common that structures like the facet joints are placed under increased irritation with cervical extension. You may also see, for example, that if you have a patient who suffers with osteoarthritis of the cervical spine, extension can be one of their most aggravating movements because of the closing down of the joint. However, it's important to note that other structures such as disc or such as soft tissue can be irritated by cervical extension as well. Next, we have to consider whether the patient's pain is reproduced locally around the neck or peripherally as well. A spinal stenosis, which is a reduction in the size of the vertebral canal, occurs during cervical extension. So therefore, if your patient presents with peripheral symptoms when they extend their cervical spine, it may be due to this stenotic pattern. So that's P. Now we're going to consider Q. With regards to quality of movement, hinging is one of the most important things to analyse. Hinging occurs due to a lack of segmental control between each of the 7 cervical spine vertebrae. So for example, if when you analyse your patient's extension, all of the extension occurs at a particular place, such as here, then that might tell you that this is where all the movement is occurring. And if excess movement is occurring at a particular place, this might create the patient's pain. So you should look at when the patient does extend, if they do hinge, is that the place that they get their pain? And if so, then segmental control of the cervical spine is something you need to analyse. The other thing to look at is whether there is increased side flexion when the patient extends. So for example, do they extend their neck and across to the right side, or do they extend their neck and come across to the left side? As we were saying with flexion, this may be due to one of two reasons. It may be that they are naturally adapting their movement in order to avoid pain, or it may be because joint structures or soft tissue structures are forced to achieve this movement because they're either stiff or because perhaps soft tissue is weak. Finally, normal range for cervical extension is 60 degrees. So if your patient is not achieving 60 degrees, it may be that you need to consider some of the things we've been talking about as to why they're not achieving their full movement. So now we're going to look at cervical rotation in an active manner. For this, the therapist classically stands in front of the patient. I'm standing in this position at the moment just so that you can see things more clearly. So now we're going to ask our patient to rotate their neck to either side. We might ask our patient to start by rotating as far as they can round to the right. Now we can apply our overpressure. In terms of the overpressure, we have to take up a particular position. So if the patient is rotating to the right, the therapist's right elbow goes on the back of the right shoulder and on the left side of the temple. This is to block any thoracic rotation on the right side. The left elbow goes in front of the patient's left shoulder with the other hand on the back of the skull. And again, the elbow blocks the rotation of the thoracic spine and allows for gentle control of the neck movement with the hands. So that's towards the right. Then we ask our patient to go across towards the left as far as they can go, and we repeat the overpressure again. This time, as the therapist, my left elbow is going on the back of the patient's shoulder, and the hand goes on the right side of the temple. My other elbow, my right elbow, goes on the front of the shoulder to prevent any thoracic rotation, and the hand on the back of the head so that we can control the movement of the neck like so. So that's the overpressure and the active range of movement. You should now see the muscles involved in cervical spine rotation coming up on the screen. So next we're going to analyse P, Q and R in terms of cervical spine rotation. And first P. Consider whether or not your patient is getting pain on the same side that they're rotating to or on the opposite side to the one that they're rotating to. For example, if our model rotates across to the left, if they report more of a global pain or a stretching sensation, it might well be because the muscles which have to stretch in order to allow for opposite side rotation are stretching further than they are happy doing, which recreates pain as well. So those are some ideas for why they may be getting pain on the opposite side. However, when they're getting pain on the same side as the one they're rotating to, it's less clear-cut as to what might be causing the problem. It may be due to a disc problem, it may be soft tissue, it may be joint as well. So that's in terms of P for pain. Next we're going to have a look at Q for quality of movement. And if you've seen our video on cervical spine observation, you'll be very familiar with what we call a pokey chin posture. This is where the cervical spine is in a protracted position, where the thoracic spine is in a kyphosed position, and the shoulder or scapula is also in a protracted position. So if we ask our model Andy to rotate round to the left slowly during this movement, you'll be able to see that the majority of the rotation occurs from the upper cervical spine, and very limited movement occurs at the lower cervical spine. It might be that this excessive movement in the upper cervical spine may be the reason that they're getting pain in this particular area, because the joint and the soft tissue structures are having to work harder. It also might be that the stiffness around the lower cervical spine, because of the lack of movement there, may be the reason they're getting pain in the lower section. Next, have a look to see whether your patient flexes or extends their neck more when they perform cervical rotation. When patients extend their neck as they rotate, it's likely because they are aiming to achieve more rotation from the lower cervical spine, potentially because there is pain on the upper cervical spine or a stiffness on the upper cervical spine, meaning that they have to utilize the lower areas in order to rotate. It may also be that they have to flex as they rotate, like so. And that might be because the upper cervical spine is more mobile, whereas the lower cervical spine is less mobile, and therefore they're trying to generate as much movement from the upper cervical spine in order to attain the movement. So that's in terms of cue for quality. Finally, range. A normal expected cervical rotation is 80 degrees to either the right or the left sides. So if you're getting a restriction in that movement, it may be due to one of the things as we've suggested previously. So now we're going to analyse active side flexion in terms of the cervical spine. In general, the therapist would stand in front of the patient so you can accurately see the movement, but just so that you can see on the camera, I'm going to be standing to the side. So first of all, we're going to ask our patient to bring their ear towards the shoulder, and that's the most common command that you give, ear diagonally towards the shoulder. So that's how we test the normal movement. If we want to apply our overpressure, one hand goes on the opposite shoulder girdle in order to prevent any excess elevation, and the other hand comes down on the side of the temple to do the movement. You may not be able to see, but my opposite elbow is also generally stabilizing the right scapula. So that's towards the right, and then in terms of the left, we ask our patient to recreate the side flexion movement, one hand stabilizing the right shoulder girdle and the other to bring the neck into gentle overpressure towards side flexion. So that's the movement. On the screen now you should see the muscles that control side flexion of the cervical spine. So now we're going to look at P, Q and R. Firstly, in terms of pain. With this movement, again, you can consider whether the patient is getting pain on the same side as the side flexion or the opposite side. For example, if we ask our patient to side flex down towards the left, the muscles on the right hand side will be on a stretch to allow the movement to occur. So if your patient presents with pain on this side, it might be because those muscles are on a stretch, which is causing their irritation. However, if your patient reports pain on the same side that they're side flexing towards, it might be due to a joint irritation because the facet joints close down on the same side that we're side flexing towards. You'll commonly see patients who present with osteoarthritis getting more pain towards the side that they are experiencing their pain when they're producing the side flexion movement. So that's in terms of P. We're going to consider R and Q together. General range of movements for side flexion is 45 degrees. However, you'll see when you analyse the patient's quality of movement, there are a number of different cheats that they may use to achieve more than that. For example, if I ask Andy to come into right-sided side flexion, you can see he achieves more than 45 degrees. The most common three cheating movements with regards to side flexion are 1. Elevation of the scapula on the same side that they're side flexing towards to offload some of the different structures on the same side. Number 2 is increased thoracic side flexion in the same direction that they side flex. And number 3, and potentially the most common out of those three, when the patient simply rotates instead of side flexing. As we said, these are different cheats that your patient may try to put into the movement to make it easier for them. So just so you can get a clear, isolated presentation of side flexion, see if you can eliminate these different cheats, and then you can get a good idea of how they are side flexing. So in this segment, we're going to show you some ideas that you can use to try and improve your patient's pain or their range of movement after you've tested the active range of movement of the cervical spine as a whole. So firstly, if you have seen our video on observation of the cervical spine, you'll be familiar with a pokey chin posture, as we like to call it. This is where the cervical spine is in more of a protracted position, increased thoracic kyphosis, and increased scapular protraction. And you may find that when your patient does their range of movement in this position, you elicit pain. So one thing you can certainly try is to reduce this posture, bring them to a more upright position, and then retest range of movement from there, asking the patient to flex the cervical spine, extend the cervical spine, rotate and side flex as you choose to. And if that is better in terms of their pain compared to how they were in the pokey chin posture, you can easily and directly show the patient how their posture influences their pain. Another thing you can do is just increase thoracic extension even if they don't present with a pokey chin posture. So even if you just have a patient who's a little bit more forward than normal, you can increase the thoracic extension and do the same thing. Again, it's a great sign for showing patients where their problem arises from and how they can easily correct it. Another thing you can see, if your patient presents with a very depressed and protracted shoulder, depressed being downwards and protracted being quite forwards, change the scapular position and see if that changes their pain. So it might be that we have one hand on the front and one hand on the back of the scapula, bringing them into a more neutral or even in an over-exaggerated elevated position, and then again ask the patient to go through their movement, maybe some flexion, some extension, particularly rotation for this position should improve their symptoms. And again, it's a really good way of showing the patient how their scapular position influences their pain and what they can do to improve it. Another way you can do this to allow the patient to do this as a treatment at home is to have them sitting on a chair, maybe with their arm elevated on a table, and then they can therefore relax the shoulder girdle in this position so that they can themselves complete their active range of movement, and it can improve their pain levels because of the improved shoulder girdle position. Finally, a really good tip for those patients who hinge when they go into extension. And we talked about hinging before and how this demonstrates reduced segmental control at different levels. So hinging, as we said, is where you might find that the patient extends from one particular spinal segment. So if you want to increase their extension at different spinal segments, you can use tapping at different segments to provide some proprioceptive feedback, and you'll quickly see that this can improve their extension. So for example, if I can ask my model Andy to extend his neck, I might be able to tap on this place, which gives him more of an idea to extend from the upper cervical spine, or indeed on this section to enable him to extend from the lower cervical spine. You'll be surprised at how quickly that proprioceptive feedback can change the patient's extension. And so you can compare their cervical extension pain or range of movement when you don't tap and when you do tap. So you can show them the difference between hinging and when they have improved spinal segment control. Now, a quick note on combined movements. Combining movement in one plane with that in another plane can give us even more information about our patient's condition. An example of a combined movement may be asking our patient to extend their cervical spine and holding the extension while side flexing to either the right or left. So what extra information does this give us? First of all, it can allow us to explore a particular functional activity in more detail. For example, a secretary may say they always have pain when they look at their documents on the right side of their desk, which we could interpret as cervical spine flexion combined with an element of right side flexion. We could thus explore this combined movement during our objective assessment and compare it to flexion with left side flexion. Therefore, if flexion and right side flexion is more painful, this would match with our patient's previous comment. Another reason for combined movements is to test joint and soft tissue structures under full stress. So if we complete combined movement testing of the cervical spine, in addition to accessory movements through palpation, and our patient's symptoms are not reproduced, we can effectively clear the cervical spine as a source of our patient's pain, as no pain has been reproduced when the joint and soft tissues of the cervical spine have been placed under full stress. So here you can see the combined movements of the cervical spine. First, we have our patient performing the movement of extension, combined with side flexion to the left, and then extension with side flexion to the right. Furthermore, you could turn this around and ask your patient to side flex before extending their cervical spine in order to test all quadrants of the movement. Next, we have cervical spine flexion, combined with side flexion to the left, and then cervical flexion with side flexion to the right. Again, you could turn this round and ask your patient to side flex before flexing their cervical spine to test all quadrants of the movement. So to summarise this video on active range of movement of the cervical spine. First, clear the shoulder and consider whether or not you need to perform a cervical spine neurological assessment. Have your patient in a sitting position before analysing cervical flexion, extension, side flexion and rotation. For each movement, look out for P, Q and R. P for pain, Q for quality of movement and R for range of movement. You can also use some of the ideas we presented in which you can change a patient's position or movement in order to improve their range of movement and their pain levels. And that completes our video on active range of movement testing of the cervical spine. In practice, you would now compare your patient's active range of movement with their passive range of movement, and by doing so it will allow you to make a decision as to whether it's most likely to be contractile or non-contractile structures which are at fault for their symptoms. You can also use other tests to confirm your patient's diagnosis. If you're not quite sure on how to interpret the active range of movement and passive range of movement findings, check out our videos titled Why Test Active Range of Movement and Why Test Passive Range of Movement, and then join us back here on Clinical Physio for the next video. Thank you as always for watching, and we'll see you again soon.